Hello everyone, today we're going to be covering the lower respiratory system. We're going to start with infectious and inflammatory disorders. First, we're going to start off with talking about acute bronchitis. This is an inflammation of the mucous membrane that lines the major bronchi and the branches. Some causes: it can be a viral, bacterial, fungal infection, or a chemical irritation. Some signs and symptoms: you have a fever, chills, malaise, headache, a dry irritating cough. Usually it's a dry hacking cough that is worse at night. Medical management: the biggest things we're going to suggest bed rest, trying to get rid of that fever with antipyretics, expectorants, antitussives, and increased fluids. And if it is a bacterial infection, we will provide antibiotics. Nursing management: we're going to monitor lung sounds and vital signs. If they're in the hospital, it could possibly be around every 4 hours. We're going to encourage them to cough, turn, and deep breathe every 2 hours. We can recommend humidifying the air if they're not hospitalized. We want to teach them not to swallow the sputum, but to actually get rid of that sputum. Acute bronchitis is common in children 1 to 4, patients that have chronic respiratory diseases, and clients that smoke. Pneumonia is the inflammatory process affecting the bronchioles and the alveoli. This is an acute lung infection in which the alveoli are filled with exudate, which reduces the surface area for the gas exchange. So this means you have an increased exudate or fluid and decreased movement of your O2 and your CO2. There are different categories. The first is your community-acquired pneumonia, which is the most common, which means it's contracted in the community setting. You have healthcare-associated pneumonia. This is usually seen in long-term care facilities, or they could be diagnosed with it 90 days into the hospitalization. You then have a hospital-acquired, which occurs more than 48 hours after admission to the hospital. That was not present on admission. Then you have a ventilator-associated, which occurs 48 hours or more after endotracheal intubation. Those are just some different types of ways to catch pneumonia. People that are at risk would be your elderly, your hospitalized, your intubated patients, the immunocompromised patients, patients that are smokers, and your immobilized patients. Assessment findings: for bacterial, it's usually sudden, and you can have fever, chills, productive cough, discomfort in the chest wall, malaise, and a rust-covered sputum. With viral, viral has a lower mortality rate. It usually takes longer to recover from, and with viral infections, chills are less common, and you have more copious sputum. With pneumonia, you can hear wheezes, crackles, or a diminished breath sounds. They can show signs of cyanotic. We are going to be medical management. We can do antibiotic therapy if it's a bacterial infection. Hydration: remember, if we take fluids, it's going to loosen those secretions. I'm going to give them oxygen, suggest bed rest, chest physical therapy, postural drainage, medications, which could consist of those bronchodilators. So, nursing management: we're going to do our respiratory assessment, obviously looking for our lung sounds, doing our pulse oximetry, monitoring our ABGs. We could also look for cough and sputum assessments. How are we going to position the patient, which should be semi-Fowlers. And the biggest thing with pneumonia is we want to catch it before they actually develop it. So we're going to try to look at prevention. If you look in box 21-2, you will find a lot of preventative ways to prevent pneumonia. Some of those could include your flu vaccine, your pneumonia vaccine, coughing and deep breathing, correct hand washing, and if they are on a vent, making sure we're suctioning them appropriately. Pleurisy is the inflammation of the parietal or the visceral pleura. Big assessment findings is shallow respirations and excruciating pain, dry cough, fatigues easily, dyspnea, and you could possibly hear a friction rub. So with this, the pleura is so inflamed that it's literally rubbing each other, and that is why you have that friction rub, and it has excruciating pain, especially with breathing. Our medical management, medical management, we're going to provide any kind of pain medication we can, antipyretics if they're having any kind of fever, and we're going to give NSAIDs, which helps with that inflammation. Nursing management, we can apply heat and cold pads, splint the chest, and this can be done by turning the patient onto the affected side. And emotional support. Here is an image of what a normal lung would look like compared to one that has pleurisy. Pleural effusion is an abnormal collection of fluid between the visceral and the parietal pleura. This can be caused by TB, lung cancer, cardiac, which would be your congestive heart failure is a main one, having that extra fluid which is going to build up around the lungs. Assessment findings could be fever, pain, dyspnea. Diagnostic findings, we're going to look at chest x-rays. You can do a CT, and we could complete a thoracentesis, which we'll talk about in just a second. Medical management, we're going to give antibiotics if there's any bacterial infection causing this. We're going to give the cardiotonic drugs, which means if there is a congestive heart failure issue, we're going to make sure we're trying to control those. Patients can also receive a chest tube. For us, nursing management is we're going to learn how to prep for a thoracentesis, and we're going to learn the functions of the chest tube and how they drain. So normal fluid in the pleura is about 5 to 15 mLs because that helps with the friction. So anything above that is what is going to cause this pleural effusion. Talking about a thoracentesis is when a needle goes into the pleural space, and it's usually to aspirate fluid. This is usually done for a pleural effusion. The patients are not put to sleep. They are usually done in x-ray, so they can be x-ray guided. They will use local anesthetics. We have to learn how to make sure we're positioning those patients correctly. We're going to position the patient sitting on the side of the bed, bending over a bedside table. If they are not able to get into that position, you can have them in a sideline position, and they're going to lie on their unaffected side. The reason we put them in this position is it opens the spaces between the ribs, so it gives them more access to where they need to go. A lung abscess is a localized pus formation. It can be caused by aspiration, bacterial pneumonia, a mechanical obstruction. Usually our assessment findings are going to consist of chills, fever, weight loss. They can have chest pain and a productive cough. They can have purulent or blood-streaked sputum, and they can have finger clubbing. When you're listening to their respiratory, they can have a dull or an absent breath sounds with possible friction rub. Medical management would be postural drainage, antibiotics, and there could be some surgical management such as the thoracentesis that we just talked about, or a lobectomy, which removes the abscess and the surrounding tissue. Some nursing management, we're going to monitor antibiotics if there's any adverse effects. We are going to perform chest physical therapy. We're going to make sure they have a diet high in protein, and we're going to provide emotional support, remembering to have them turn, cough, and deep breathe. Here are some images for postural drainage. So depending on what area of the lungs you're wanting to do, there are different positions to place your patients in to help with that drainage. Influenza or the flu is an acute respiratory disease. Some major strands are your A, B, and C. These patients are going to be on droplet precautions. They can be transmitted by talking, coughing, sneezing. Your assessment findings you can find on table 21-2. They can have a sudden onset of fever, chills, headache, muscle aches, with the fever lasting around 3 days. As it progresses, you can see signs of anorexia, malaise. They'll start sneezing, complaining of a sore throat, and have a dry cough. Some medical management is the biggest thing is we want to try to prevent it, which is that flu vaccine. If they're in the hospital, we need to have them on their appropriate isolation. They are contagious 1 day before they feel ill and can be contagious up to 5 to 7 days after. So we just need to make sure that we are doing correct precautions. Nursing management is prevention with the vaccine administration. There are 2 different types. You can get an IM or a flu mist. The IM vaccine is an inactivated, while the flu mist is a live vaccine. If you look on page 326 of your TIMBY book, it'll tell you who cannot have the flu mist because it is a live vaccine. Lastly, we're going to talk about pulmonary tuberculosis or TB. This is a bacterial infectious disease. This is an airborne, and bacteria remain dormant. They can remain dormant in the lungs until a later time when the clinical symptoms appear, which sometimes they never appear. However, sometimes they appear when a patient becomes immunocompromised. Here are some assessment findings. Most people can be asymptomatic. If there are symptoms, they can have fatigue, anorexia, weight loss, a slight non-productive cough. Later, they can have night sweats, a cough that is productive, weakness, wasting, dyspnea. Some diagnostic tests are your skin test, chest x-ray, CT scan, MRI, and a T-spot test. The skin test shows that the client had been infected or that the disease existed in them at some point somewhere in the body, but that doesn't mean that it's active. If a patient has had the Bacillus Calmette-Guerin vaccine, BCG vaccine, their TB test will show a false positive. The BCG was a TB vaccine used in other countries. I know there's a lot of TB, BCG, but so then you have a T-spot. The T-spot also measures a client's immune reactivity. You can get these results in 24 hours, and these are not impacted by the BCG vaccine. The TB or the BCG vaccines were as a TB vaccine that was used in other countries. So we don't see it very often here, but there are some that did get that vaccine. Some medical management is your drug therapy. The most common is INH, which is metabolized by the liver. So we need to make sure what their liver function is. And Rafidin. These medications are normally given for 6 to 9 months. They are trying to reduce it to 12 weeks. But either way, this is a very long time, and so compliance with these medications are very important to educate your patient about. In order to go back to work, they have to have 3 negative sputum cultures. And normally if they ever show a positive, they're always going to show that positive, which means they're going to have to go around doing the chest x-ray or changing to a T-spot. So just always make sure we're looking for those as well. All right, here is the question of the video. We'll see if y'all get it right when you come to class. See you soon.